special guest joining us today is Professor Bill Runciman, who's the Professor in Patient Safety and Healthcare at the University of South Australia and also Director and President of the Australian Patient Safety Foundation, a role he's had since 1988. So thank you very much, Bill, for joining us. Where are you today?
I'm actually in Dungog.
Oh, very nice. How's the weather
in Dungog? Which is north of Maitland, as you may know. Oh, it's raining.
Oh, well, that's probably good. They're probably looking forward to the rain in Dungog. Bill, you've made a study for many years about the factors that influence our ability to provide reliable and safe and high-quality healthcare. How are we doing? Do you think in Australia we do deliver person-centred, safe, quality healthcare?
Well, by international measures, Australia performs quite well. I would say well, in fact. A great deal better, of course, in the United States of America. Not quite as well as France or one of the Nordic countries, but it's a universal healthcare system, as we know. And the OECD indicators, we do pretty well. But at the same time, there are lots of things which we don't get right, either by making the wrong plan, in other words, inappropriate care, or by flawed execution, which is regarded as unsafe or low quality, or care not the highest quality. And if this can be, these problems can be addressed, clearly we should do so, especially if it can be done in a cost-effective manner.
So tell us about the appropriateness of the healthcare we deliver, Bill.
Well, we did a study which we called the Care Track Australia study, which I'll talk about in a minute, in which we looked at what we called appropriate care. We looked at 22 conditions, 520 indicators taken from guidelines, the things we thought should be documented. And we showed that about half of care that is delivered in Australia on a population sample is what we would call appropriate. The rest is not inappropriate, it's just not the best care. And this is in a system which, as we know, is becoming strapped for cash. It costs 10% of GDP. And we're currently foregoing some very good, new, modern, effective treatments because of shortage of funds.
So if we can deliver less inappropriate care, we've got a greater chance to deliver more appropriate care, and our needs for our needs in health, as we know all the time, are increasing. You say there's a perfect storm of problems approaching.
Yes, I mean, this is exactly right. This is happening certainly in all developed countries, but worldwide. An aging population, increasing possibilities. There are unquestionably new, better types of care coming along all the time with non-invasive procedures, with molecular engineering and so on. And there obviously is a limit to funding for healthcare. Current extrapolations say that health budgets could consume in the whole of state budgets within a decade. And so we face this affordability crisis, and every time we do something that's not entirely appropriate, there's an opportunity cost, and we can't do something that is more cost effective. So,
so you say, according to your studies, that about 60% of our care is appropriate, which leaves us with 40% of care, which seems an enormous amount of care, being inappropriate.
Yes, yes, 40% approximately is not in line with clinical practice guidelines, which are either evidence-based or consensus-based. Although one can debate those, but that's about the figure. And I'll talk in a minute about why we think that might be the case.
So you studied that in the Care Track study. Was that that was certainly had enormous exposure as being influential, and it's been a very influential study.
Yes, so we set out to. Yeah, we set out to try and replicate a study done in the United States by the RAND organization, and we asked 3 questions. What percentage of healthcare is appropriate? and we defined that as being in line with the latest clinical practice guidelines, which are based on evidence-based or consensus-based care. We asked the question, what drives clinical decision-making from the perspectives of both healthcare providers and healthcare consumers, and that was done by interviews and so on. I'm looking at a couple of PhD theses at the moment resulting from that work. And another question is, what do we need for the ongoing surveillance? Because we don't know who's getting what from whom. It's difficult to have logical health policy. And because we anticipated that there would be some deficiencies based on the literature for individual conditions, we also wanted to ask the question, how can we fix the problems? The problems from two perspectives. One, to be able to have healthcare under surveillance easily and cheaply, and continuously, ideally. And the second thing is, of course, how can we get healthcare to change in a manner that's more nimble and more continuously aligned with practice following the latest research. So that was the study.
Well, you know, that's a challenge from our work in the collaboratives. We are looking at the quality of the data in primary care. It took 3 to 6 months of work for most practices to have the data that's entered in their databases to the standard that reflected what they're actually doing. And then when we started to measure practices that considered they were delivering the highest quality care, we were all surprised, my practice and others, to see how often we were falling down according to the guidelines.
Yes, there's nothing quite like measuring something to get surprised usually. Yeah, so it's as you say, expensive and difficult to do. We had a program grant just to look at about 1,200 patients' records. That's all their records. Cost us about $2 million. And the quality in Australian healthcare we did on adverse events, and just to find about 1,200 adverse events cost $2 million because the records are not systematically compiled. So I mean, just to look at some figures there, when we looked at 22 conditions, that was limited by the amount of money. So we then look at the more prevalent things. We chose 522 indicators of things which could be answered, which we thought were, many of them are no-brainers, you know, listening to the chest in left ventricular failure and stuff like that. We had to make 35,000 telephone calls to recruit just over 1,100 patients. And that is to get their permission and the permission of their practitioners. We had to get ethics from over 220 sites, which is an excellent way of aging and getting grey hair.
Yes.
We assessed over 250,000 healthcare encounters, and of those, 35,000 were eligible. You know, an ineligible encounter, for example, would be a question about pap smears in males, you know.
Yes.
So
what an enormous amount of work, Bill, over, I suspect, an extended period of time. What did you find?
Well, I don't want to go into detail, but we found, as you can see, compliance according to our indicators for conditions ranging from about 10% to up to about 90% for coronary artery syndrome. Very wide confidence intervals, reflecting very great variability in care, and this was a representative sample of Australians. And just in brief, just a couple of facts and figures. Some practices were compliant as high as over 85% of the time, which is exceptionally good. Others were compliant as low as 25 or 30% of the time. As you see, the spectrum or range for individual conditions is there. Generally speaking, reactive activities, such as treating something which comes along, were reasonably well done. But risk assessments and proactive things were almost not done at all. Things like, you know, assessing risk for type 2 diabetes or cardiovascular risk and so on. That was right down below the 5% mark. So if something's done well, something's not done not so well. But the interesting thing is there were practices that performed at a very high level. So it is obviously possible.
And on that graph, we see the coronary artery disease was managed, but around the 90% in line with where we would expect it to be. Alcohol dependence on the other end of the, terribly inappropriately well managed. How, Bill, the next question then is, having established that care is not reliable and consistent across a range of practice, we've been trying over the years, of course, it's been our mantra to make good practice normal practice. What hasn't worked? What do we know doesn't work when we try and change clinicians' behaviour?
Well, I mean, the short answer to that is most things don't work. The EPOC, I can never remember what it stands for, but it's the Cochrane Collaboration on Effective Practice and something or other. It looks at the evidence for the normal sort of interventions to improve practice. And the effect size of the interventions ranges from about 4% to around about 12%. And that includes, champions and breakthrough series and guidelines and a whole lot of things. And it seems that there's very powerful homeostatic mechanisms which to keep what people's practice stable. And I want to speculate on that in a minute. There is no easy magic bullet. There is no simple way of doing things, and certainly the conventional thing like, having a series of lectures that people go along to really don't work very well, and they're not cost effective.
So having the professor come and tell us how we should manage alcohol dependence or coronary artery disease and what the evidence is, going to a lecture and getting education about that has limited success in changing behaviour, but that's the way we continue to try and that's what we continue to try and do.
Yes, I guess one of our arguments is more of the same. We've really done the experiment many times of more of the same in the last 20, 30 years, and we know that if we do more of the same, we get more of the same. And so we do really need to change things.
So our participating practices, we're familiar with the concept that every system produces exactly the results it's designed to produce, and if you want to get a different result, therefore, you need to change the system. Bill, therefore, my desk, I'm in my office now, and it's covered in guidelines for all the different conditions that I might see. Are guidelines the answer? Do we need better or stronger or more frequent guidelines?
Well, not in the form in which they are. It's one of the things we looked at. We looked at the guidelines. As you know, they're voluminous. They are hard to assimilate. Many people don't even know they exist. Few people have read them, certainly from cover to cover. They're called guidelines. They do anything but guide, in fact. They're sort of aspirational documents almost. They're a good resource of information if you want to look something up. Lots of hard work's gone into them. But of course, they're by definition, they're out of date before they go to press. And that's another problem. So the other thing is they tend to be a burgeoning number of guidelines. We can't keep adding guidelines and protocols and pathways without getting rid of other ones, because it makes it, I think the situation you're in is probably almost impossible to manage. So we need to exploit the digital revolution in a manner that where we collectively do something with it. And so I'll get on to that in a minute. Yeah.
Well, 50% of my patients over 65 have three or more comorbidities, and the guidelines don't reflect that. Bill, the burden of disease is something we hear just started to come up in conversations, and it really worries me when I find that my patients are meant to be undertaking so many activities every day and devoting their life to managing their conditions.
Yes, there's no question that, and we've got good data which we haven't published yet, basically showing that as the number of conditions increases, so does the compliance in terms of management of each individual condition decreases. So we need to very much streamline the information to inform patients and practitioners and guide care, and we need to put some smarts into some ways of doing it. The challenge is going to be making this fit in with workflow, because it really is a challenge, and as we all know, interposing a computer between a doctor and a patient is not ideal.
No, I remember a talk Professor Larry Weed gave where he said the old model where the all-knowing doctor, given all the hundreds of inputs into a consultation and the possible outputs, which range from ordering tests or prescribing medication or doing an operation or providing preventative activity, if we expected to get, using one doctor's head, if we expect them to get that right 30 times a day, given 15 minutes per occasion every day of the year, then we're crazy. And we need a much better system to support even the best doctors in making these sort of decisions. That would, I guess, be part of what your findings and suggestions involve.
Yes, I mean, you know, I guess the slide there, the wicked problem, it points out that baselines are relatively poor. Interventions lead to little change. Change is often not sustained. The effect of the traditional interventions is not great. And the question is, well, why should this be so? And I'll just go on to this hypothesis which we're thinking of trying to test. Daniel Kahneman was a guy who won the 2002 Nobel Prize for Economics just doing thought experiments, and you can buy his book at the airport on System 1, Thinking Fast and Thinking Slow. The Thinking Fast is the System 1 thinking. And really, doctors are busy. Busy people have to use System 1 thinking to get through the day. This is virtually automatic. It's virtually beyond your voluntary control. And this book goes into this in some detail. Because doctors see the common things very commonly, as you say, all day. You might see 30, 40 patients. You might do lots of consultations. It means that this is really done. There's not a lot of new thinking going on there. Routine care is almost impervious to change because people are virtually forced by circumstances into falling back on their tried and tested routines. What I've got there, the production pressure paradox, is that if you come along with an unusual condition, you'll probably get it much better treated because the whole cognitive process is different. There'll be a stop, but there'll be history will be taken and people will be phoned up to get advice, etc. And so the paradox is that unusual complex problems, which are fairly rare, may be better managed than the routine ones in which almost everyone has got into habits which are not always the right habits. And then the question after that, the question after this was how can this be changed? What can we do about it? And this is another psychologist, because Kahneman was a psychologist, but he got a Nobel Prize in economics. And Don Norman, he's got a couple of books. I don't know if you've come across them.
I've read The Design of Everyday Things, which is one of my favourite books. I'd recommend it.
Yeah, fantastic.
The Norman door is the door where you can't work out whether to push it or pull it. It's so easy to give indications on the door without writing push and pull, but nobody ever does it. And it's a fantastic book.
That's exactly right. It's a very good book. It's worth reading, and it's another one called The Things That Make Us Smart. So Don Norman basically says what we need are forcing functions. We need to change the affordances of the system. So if a door opens into a corridor, and when you open it, knocks the tea lady over, well, you need to make the door open into the room. So that's changing the affordances of the system. That's a crude example. But you need to make it easier to do the right thing and harder to do the wrong thing. And this is introducing some force-in functions, or even subliminal, subtle forcing functions, which have been called nudges. And it's said that was done in Obama's re-election campaign, that people were working on that philosophy. And obviously, when you've done the right thing, if you get rapid, transparent, relevant feedback, which indicates that you've done the right thing in some very quick and easy way, like something changing color or position or whatever, then that's been well shown to work. Also, providing incentives to do the right thing or disincentives to do the wrong thing can be another approach. So we're proposing, and in the light of all this, first of all, I think anything we do should be a population-based approach. If you look at the literature, it's not easy to find population-based figures on how the healthcare system is performing or what people are doing. It's very often one profession, it's often one group, it's often one area, it's often one disease, etc., or one treatment, which is not generalizable. and therefore is of course of limited relevance to everyone. So we're proposing that we first of all that we create agreed clinical standards. We take the stuff in the clinical practice guidelines and we put a straw man up. We put up a wiki with a proposed set of points. It's inclusive, so anyone can register for the wiki. It's transparent, so that everyone's will provide their conflicts of interest, but their identity will be kept confidential, except for the research team who can look at their comments in the light of their conflicts of interest. But then all the comments will appear, either the ones that are accepted and go into the thing, or which are put to one side, but there'll be reasons as to why they're put to one side. And anything is accepted or rejected, the provenance of that process will be transparent. The idea then is to embody the things which survive this process in indicators, and to come up with a series of electronic tools which will comprise a series of indicators which ideally will be embedded in the workflow in a manner that's easy to do. Now all of this is of course is easier said than done. I'll just quickly go into what the tools will, what we're calling a tool. The tool will really be like an app, an electronic app. And of course there are thousands of those. So what's different about the ones we're proposing? Well, first of all, they will be based on a transparent consensus process. The second thing is that will have been transparent and take into account conflicts of interest. But the tool will then do four things. It will tell patients what to expect. It will guide clinicians what to do. It will have little boxes so that you can document what was and was not done with the reasons, because very often something may not be appropriate, in which case we simply request that, or for a standard ask that a quick reason be given. The patient didn't want it, or they're allergic to it, or whatever. Having done all of that, the next step is to have software which makes this amenable to audit and tracking electronically and automatically. And there'll then be the basis to look at individuals, what individual practitioners are doing, what individual patients are doing, and the ability to inform evidence-based policy, so that if some areas are being done well, we don't have to worry about them too much, but if in other areas need attention, there can be attention shown to that area. So that's really the overall idea.
So Bill, so if I could get a feeling for what that might be, if a patient came and sees me after lunch and they've got low back pain, then the tool might pop up with advice to, what the evidence is, which may be
so
mobilise and analgesia and don't do an X-ray at this stage, or
the front screen, which will go on an iPhone, will have four headings: basic information, assessment, first-line care, and second-line care. And there's four dot points: red line problems, red flag problems, very severe pain, recurrent pain, and chronic pain. So then, if you go, for example, if you click on basic information, you get a screen which says back pain is very common, almost everyone has had it. Next thing it says, it may be very painful, but usually only lasts days to weeks. The third thing is the largest single cause of disability in the world. The fourth thing is over 95% of cases are non-specific, a poorly understood self-limiting condition thought to be due to minor tissue damage. And the fifth thing, it says that assessment and treatment are currently often not appropriate. And obviously you go on there to assessment, which, for example, if you clicked on assessment, it would tell you, what to do, and state specifically that imaging is only recommended in a very small percentage of cases, etc. So and as you click down on each thing, you can go through layers, of course, right down to the provenance of that statement and the references that were relied upon to make an assertion or to explain why something is not actually in the algorithm.
So if I choose to go against the advice and perform an X-ray, then I tick the box and I can write a comment why I might do that, and your team will use that sort of information not to hound me, but to inform the tool for, maybe even inform the evidence.
we want to develop proof of concept, etc. We want to send up a generic method. So ideally, there would be no one involved except the practitioners and the patients and practice managers and so on, because people would be getting their own feedback as to what they're doing. You could. I think why we're calling it a standard is it's something that you really would expect to happen if your relative went in and saw someone. If they've got systolic heart failure, you'd expect them to be on an ACE inhibitor, if you know what I mean. If they've got back pain, you'd expect them to be told to try and avoid go to bed and to try and keep active as best they can, given the pain that they're in. So it's that sort of basic stuff that we think should be here, and we believe that that sort of basic stuff can be agreed upon, which would free the patients and the practitioners up from what I would call housekeeping to have a sensible discussion and establish rapport and do all the rest of it. It also, a lot of practitioners will say that they're pressured by, and my own experience is the same, are pressured by relatives, are pressured by people they want an MRI scan for their sore back. They want antibiotics for the kids' otitis media, etc., etc. And I think if you can say, look, well, that's actually runs counter to the evidence-based guidelines that our college recommends, and the idea is they will be endorsed, of course, by the relevant professional bodies. So to discriminate them from the many other apps that are out there, some of which are good, but not used very much because they're done in rather a turgid way, and some of which are complete rubbish, and some of those are very popular.
So one of the things that appears to make what you're planning different from others is that it's a shared decision-making tool. So it's designed both for patients and for clinicians to come to a shared decision about what to do.
It's shared decision. It'll have an impeccable, what we're calling a provenance. It will be endorsed, and it, above all, and this really is often where it falls down, it won't talk down to people, but it'll be in plain English, and that's in my view enormously important. I've been involved quite a bit in definitions and terminology and so on with the World Health Organization, and if a definition runs more than a line with more than one concept, it's not going to survive as a useful object. You have to have a single concept per line, and not try and qualify things and make it complicated. And of course, how do you do that? Well, you do it by you can have each words highlighted that if you click on them, they're then defined. If you click on the other ones, they're then defined. But you do it one concept at a time. Otherwise, people's brains just close down.
So, well, that's fascinating, Bill. What stage of development are you up to with your tool, and can the practices that are participating in any way, when can we expect that we might be able to participate or be trial sites or have a look?
Well, we would hope, we would encourage people to register. We're hoping to go live, if you like, in probably February. January's not a time to do it. We've been working on the wiki process for 18 months, getting the software sorted out and learning quite a bit about a few things, and we've been obviously collating clinical practice guidelines and making tables and doing things. One project's pretty well underway, which is a gout project, which will end up with a randomized controlled trial, testing the tool. You may know that allopurinol is much kinder than people thought it was, and it's much less hard to use. It's not contraindicated in renal failure, and you can get very dramatic results with allopurinol if you, in fact, you can, prevent people from ever getting gout again if you keep the urate below about 3 millimoles per litre. I think that's the unit. So that's one cab off the rank. We want to do back pain soon, possibly acute coronary syndrome. Initially, we're concentrating on proof of concept, but we'd be very keen to get registrants to make comments and participate in the process. And as I say, people's identities are completely confidential, and all their comments will be responded to. And then, of course, subsequently, we'd be wanting to do RCTs and step wedge design interventions and so on show that the process works.
And so, Bill, if we've got a lot of techie practices who are really interested in reliable care. Where might they go to keep an eye out for when the beta's available? Is there a website that we can look at?
Well, I'm just trying to think of the best website. I'll get it put up on the School of Population Health. We haven't actually tried to recruit yet. So, can I contact the Improvement Foundation with
that'd be great.
Detail? I'll do that, because the sort of practices you're talking about are exactly the ones we're interested in the first instance.
Excellent. Oh, that sounds fantastic. Bill, I wonder if there are any questions from our listeners. They can unmute themselves. Brian, you might unmute everybody with your button, and we'll see if we have any additional questions. And we'll share that information, Bill, with that link, and we'll keep an eye out for when the beta becomes available. Gee, there's a lot of conditions to do. A lot of it's been involved in Health Pathways, which is I don't know if you've seen that program being run by a number of the primary health networks, which is similar in its aim, but it doesn't have some of the features that you've added.
Yes, I guess it's a question of working towards getting the best of all worlds, and as you say, a huge amount of stuff has been done. There's a lot of stuff out there, and it's a question, I think, of slowly refining, and apoptosis is needed as well. That is stuff to drop off once you add other stuff.
All right. Thanks, Bill. That's about our time up. I think, Bill, you're going to be joining us in Melbourne in November at the International Healthcare Conference.
Yes, absolutely. Yep, I will be. Yes, thank you.
So that'll be great. We're all looking forward to that. You can show the slide about that, Brian. I noticed there's some discounts available for QI community members, so people on the conference who haven't looked into that. People on this webinar might want to have a look at the convention program. There's a number of international speakers and a number of whom we've spoken to previously in these QIQ webinars. There was a question come in, Bill, about whether it will be more than an app. I guess there'll be a desktop version, and ultimately integrated with clinical software would be ideal.
Yes, absolutely. We're concentrating on the process of the transparent agreement, getting the content agreed, getting it endorsed, coming up with the plain English, and we're really planning. We've had little forays into software development and had our fingers and, in fact, hands and arms burned.
Yes.
So we really think that software is the appropriate people to do it on the software. The normal commercial software developers who can then interface with the various systems that you have in your practices and so on. But what's important, it's not a technical problem. It's a socio-political problem of getting agreement, getting endorsements, keeping it plain, keeping it simple. And the very big question that's coming up, which is occupying us a lot, is what constitutes evidence? I mean, what do you have to, what are the attributes of something that can get into a pathway like that? Because many things, particularly diagnostically and clinically, are not amenable to quantitative evidence. So the question then comes as, what is the nature of evidence, and so it's going to raise a whole lot of interesting philosophical questions as well.
And you've already said guidelines are out of date when they're printed. Being agile and keeping up with the evidence is a challenge.
Oh well, that's part of the process. Is there will be the groups who develop and who will self-select as being national experts, the sort of people who do the RCT. And our experience is the people who do this are keen to be involved in this. Those groups will remain continuously constituted with access to the wiki, so that the content can change. A bit like an Apple iPhone or something, where everyone says there's an update. There's an update for asthma or whatever.
Yeah.
And then,
okay.
Wow.
And general practice input into the program, Bill? Is it all going to be esoteric, or are you going to have some GPs involved?
It's absolutely intended to have anyone who involved who would like to be involved. That's the whole inclusive nature.
Fantastic. Well, that sounds like
so we're really very much hoping to get the right people. Yep.
Great. Well, that's really interesting, Bill. And we thank you very much for taking time out of your day in Dugong to join us. And we look forward to catching up with you in Melbourne. And thanks for those who've dialed in and listened. There's an evaluation will pop up when we close the meeting. Do consider coming down to Melbourne, and we'll catch you then. Thank you, Brian, for organising us all. And once again, thank you, Bill.